Hi, this is Stef. I am looking at a COPD case study. Marla has been a patient of mine for some time. She's 70, has a 50-pack-year history of smoking, was diagnosed with COPD 10 years ago, and has been doing reasonably well until about a year and a half ago. In the past year and a half, she's had 3 exacerbations, and this last one required hospitalization for the first time. Her FEV1 has been reduced to 30%, and she's short of breath with even moderate exertion, so walking 10 feet or more. She has mild right-sided heart failure with a reduced ejection fraction. So medication-wise, we've been managing her with Spiriva inhaler once a day, Advair twice a day, so she's got her LAMA-LABA ICS combination. She's also on lisinopril, metoprolol, and aspirin. Today, Marla is in no obvious distress. She's mildly tachypnic, without shortness of breath. Vital signs are within defined limits. SpO2 is a little bit low at 90%, but not below that. She has no evidence of clubbing or hypoxia. I wanted to go over the pathogenesis of COPD. It's essentially the intersection of 2 chronic conditions, chronic bronchitis and emphysema. It is caused primarily by inflammation, which is in turn caused by smoking, primarily. In some parts of the world, pollution exposure contributes. Chronic infection may be part of the problem, and for some very unlucky individuals, a deficiency of alpha-1 antitrypsin contributes. The inflammation within the lung causes oxidative stress. It causes the influx of inflammatory cytokines. Antiproteases are inactivated, and therefore proteases proliferate. Neutrophils invade. Goblet cells are increased in order to, the proliferation of goblet cells results in mucus production that just goes up and up. The death of ciliated cells, ciliated epithelial cells, means that the mucus produced by the goblet cells will end up in more dependent parts of the lung, leading to an increased risk of infection because it's stuck down there. Decreased airway elasticity is a result of inflammatory cytokines and proteases. Decreased structural support, again, these proteases are breaking down the structures of the lung tissues. And alveoli are permanently enlarged, which means that there's less surface area for gas exchange to occur. It also leads to trapping of air and of mucus. And that's basically our problem. The Global Initiative for Chronic Obstructive Lung Disease, or GOLD report, is essentially the gold standard for diagnosis and treatment of COPD. The criteria for developing COPD are the presence of risk factors, i.e. smoking, a chronic cough, chronic dyspnea, and a FEV1 over FVC ratio of less than 70%. That's classic definition. Now, there's also a classification of the severity of the disease within this report. So you have the FEV1 over FVC ratio of 70, or less than 70%. That means that you have COPD. But the FEV1 versus the predicted FEV of that individual will grade the COPD. So grade 1 is 80% or over of predicted. Grade 2 is 50 to 79. Grade 3 is 30 to 49. And grade 4 is less than 30% of predicted, which means that they're really quite impaired. Now you take that and you combine it with the actual clinical picture that we have. So if you have a patient who is grade 4 but hasn't had any exacerbations, well, that's not so bad. But grade 4 with 2 or more exacerbations, or an exacerbation that requires hospitalization, would leave the patient with a grade 4 group D designation. The other portion of this is that the Global Initiative for Chronic Obstructive Lung Disease uses a survey that is patient-based, that answers certain questions about their quality of life and incorporates that into our diagnosis and our grading of the severity of their disease. So the CAT scoring determines the group, and you can look up the CAT testing in the Gold Report. It's very short, very clear, very easy to do, and that will help you determine where this patient actually falls. Now, my patient Marla actually falls into grade 4, group D. She's had several exacerbations. Her CAT score is quite high, and her FEV1 is 30%, less than 30% or less. She's not doing too well. I'm not too concerned about establishing a differential diagnosis for Marla because she has been diagnosed with COPD for so long, and it's a well-established case with her. But I did want to mention the differential diagnoses that we need to eliminate in somebody that we're newly diagnosing with COPD. So asthma, CHF are two things that are relatively common and need to be ruled out. Bronchiectasis is essentially an enlargement of the bronchi, and it's usually related to CHF, a decreased immune response, or acute infections. Obliterative bronchiolitis is a condition where the bronchioles are restricted due to inflammation. Often has to do with an exposure to toxic fumes, infection, and bone marrow, heart, or lung transplantation. Presents with shortness of breath, dry cough, fatigue, and is basically diagnosed via CT. Diffuse panbronchiolitis is a condition that is present throughout the lung tissue. The terminal bronchioles are inflamed. There's cough with a large amount of sputum production, and it's usually due to immune suppression. Occurs predominantly in Asian male non-smokers. Here's a list of Marla's medications. We need to revisit these because of her recent exacerbations. Obviously, she's no longer as well controlled as she was in those first few years of her illness. She's maxed out on her Advair, and her Spiriva is also perfectly adequate. So her LAMA-LABA ICS combination should be working for her, but doesn't seem to be doing it any longer. The question is, adding oral steroids, that doesn't seem to help. It doesn't decrease the number of exacerbations, and it does not decrease deterioration. Some would add a maintenance macrolide, but that's not indicated for Marla because she is a gold stage 4D, and that is contraindicated. PDE4 inhibitor is a possibility, but there's not that much evidence supporting efficacy. But during our visit, Marla looks at me and says, well, what if I stopped smoking? And that's the opening I have been waiting for. I've been trying to encourage Marla to stop smoking for many, many years, but this is the best opening I've had, therefore I'm going to take it. I recommend Chantix. I'm going to tell her to pick up a prescription on the way home and to start taking it. Take it for a week and then stop smoking. The cost is high, not nearly as high as another exacerbation, so she's willing to pay for that. There's no interactions, I double-checked already. It's minimally metabolized and excreted through the urine, and it seems to be the most effective way to help anyone quit smoking. There are certain side effects, so that's something to watch out for, but Chantix is an alpha-4 beta-2 agonist, a partial agonist actually, will cause dopamine release that's 35 to 60% of that of nicotine, and that is pretty high and seems to help a lot of people. So we're going to go with Chantix, and we're going to see if she can stop. Marla and I develop a plan. She will pick up her Chantix today. She will establish contact with the main tobacco helpline to have some moral support. She might even try to get her husband to quit smoking with her. She's going to stop smoking next Wednesday on Halloween. She's going to come back to the office in a month to see how she's doing with it. We'll check kidney functions at that time, just to keep track of everything. Elevate her legs to manage her edema. Daily weight monitoring, and notifying the office for increases in weight. There is an increased incidence of oral thrush with ICSU, so rinse after using the Advair and keep moving. People aren't meant to sit still. In conclusion, COPD is progressive and non-reversible. In fact, the only thing that's been shown to have any positive impact on lung function is quitting smoking. It's a cluster of two diseases, bronchitis and emphysema. It's caused by smoking. The GOLD report uses objective and subjective data for COPD diagnosis and assessment of severity. Medications for COPD include long-acting muscarinic agonists, long-acting beta antagonists, inhaled corticosteroids, NSAIDs, and macrolides. COPD may contribute to heart failure, and heart failure may contribute to COPD. And treatment options other than medication, like as I said, smoking cessation is the most effective. But make sure that your COPD patients are vaccinated for pneumonia and for the flu. Pulmonary rehab also tends to help patients. And in very severe cases, lung volume reduction surgery to remove some of that trapped air is also done. Thank you for listening.